Women in your 30s and beyond, are you tired of being told how to feel? Like all of the products are forced on you? Doesn't it feel like these big companies categorize you when the truth is they don't know you? Listen up. I'm Dr.Jila, an OBGYN and women's health expert. This is my podcast, Her Time, Her Health with Dr. Jila. I had the fortune and the honor to meet you a couple of times in person, and we've had some quite interesting conversations about our, past lives as medical doctors. And I kind of want to start there and, have you, what we talked about, which was the rigorous training we went through and a little bit of PTSD that I think we all carry within ourselves. And for the positive and the negative sides of it, right? Let's start with that.
Okay. I got it. All right, so what was there a question?
Oh. Okay, yeah, you're so funny. So let me form the question. Luckily, This is all edited, so we're all good.
Okay.
It'll sound great later.
Okay.
So I'm going to start with some background stuff. So you're the youngest of 8 children, right? From Mobile, Alabama. Did some research. And your younger sister, Vivian, right? Was
my oldest sister.
Your sister, yes, correct. Vivian was your older sister. And she was one of the first African-American women to go past Governor Wallace at the University of Alabama in 1963. You were 4, I believe, at that time, correct? How was it growing up in that type of household, family? What kind of courage do you think where was all built up to make you kind of the advocate that you've become for women today?
Well, the whole notion of inequity and racial disparities and all that is something that, I grew up with. It's impossible not to when you grew up in the segregated South. But I mean, even the basic things, not just where you live, but where you went to school was determined by the color of your skin. And all of my 7 siblings prior to me had all gone to segregated schools in the neighborhood. And when my sister Vivian applied to college, the good news, bad news, but the good news in Alabama is that we had quite a number of HBCUs, or the historically black colleges and universities. And she wanted to go to the University of Alabama. She felt like, this is the best, the flagship school in the state of Alabama. And they had attempted to desegregate the University of Alabama, I believe it was in 1956. Autherine Lucy was the first student to actually enroll there, and they let her in by mistake. And then she showed up, and it's like, oh my God, she's black, so you can imagine.
Right.
But nonetheless, her tenure there was all of 3 days. She went to class one day. The violence was so intense that for her safety, she was expelled, after one day on campus. And the University of Alabama went unchallenged in terms of admitting another black student until 1963. So it was a watershed, very sort of contentious moment. And I have to tell you, I really think about it now as a parent, and I was like, I can't even summon the courage for what it must have taken for my parents, for my sister to show up, because, there's no cell phones, there's no way to be in touch. And it's not as if, violence was a theoretical concern. It was very real and very much so in 63. So, she did that brave thing, and she survived and she thrived in a very hostile environment. And when you grow up knowing that story, I don't think that I grew up feeling a lot of limitations about what I could do or what I was entitled to. And that's just sort of how I started this whole journey.
Yeah, and your journey, you went from Harvard, you went to Columbia, and then 30 years of practice in an amazing practice in Washington, D.C. What made you finally step away from all of that and into your bigger role, with Alloy and online telehealth?
You know what? Again, quite serendipitous. It was COVID, and I think that for the first time in my adult life, I had never had 3 months off. And when we were in the COVID emergency, and I was doing gynecology at that time, so we didn't have many gynecological emergencies. So everything had to, we shut down. And so from March to June, I had 3 months of time with my family, with my husband that I had never had before, 3 months continuously that way. And, you start thinking, and I was like, you know what? I think I'm done. I hadn't thought about it at all before COVID, and I probably, who knows, I'd probably still be at my job had I not had that time to just step back, think about it for a moment. And when I left, I had no real plan in mind. And Ann and Monica, the founders of Alloy, found me, because I did a podcast with Michelle Obama that summer, that first summer of COVID. So that's why I said I'm a firm believer in the fact that there are no accidents in the universe. You end up where you're supposed to be. And sometimes, you just have to not be afraid to make that next step. But, even if I had done nothing, to be quite honest with you, even though I don't think I'm capable of doing nothing, but but even if I had, after 30 years, it was like, I'm good, I'm good. But the good news is that I found, this new purpose. And, it's not so different from what I've been doing in my office every day, but I was advocating and talking and educating women one-on-one. And your reach can only be so far when you are doing and seeing patients one-on-one. And, this advocacy work and working with Alloy has really given me the opportunity to take what I had been doing and to do it on a larger scale. So,
and we're so appreciative of you doing that, because we can only do so much in the four walls of our offices, but when you're out there doing the other work and speaking and doing all of this, that's how we're going to reach beyond the walls of the office and get to more people nationally and hopefully globally. Walk me back through the WHI back in 2002, where you were and how you reacted to that whole thing, because I love your story with that.
You know what? See, this is one of the advantages of being old, is sort of like, I was there. I remember that. And for your listeners who may or may not know what the WHI is, the Women's Health Initiative, which was the first and the only large-scale study on hormone therapy for postmenopausal women ever. And prior to that study, which was really, I think they started recruiting in the early 90s for that. There had never really been a randomized controlled study about hormones, even though hormones had been around since 1942. Most of what we knew about hormones was, we didn't know nothing. We knew a lot about them clinically. We had used them, and we knew that they were effective for the symptoms of menopause. But over time, we had just sort of accumulated the data, the observational data, that it really, in addition to decreasing the symptoms, it decreased the risk of heart disease, but it hadn't been rigorously proven, and that was what the study was about. But even coming into that conversation, when I started my practice in 1992, we were very much advocating the use of hormone therapy for women, not just for relief of symptoms, but for decreasing the risk of cardiovascular disease. That was really what the study was about. So for 10 years, I had been prescribing and talking to women about the benefits of hormone therapy, much like we discuss it today. And then I will never forget it. The study came, even before the study came out, they held the press conference before the study came out here in Washington, D.C., big splash, media, everything. And overnight, it went from hormone therapy is good, it's good for you, it's good for your heart, to, oh my God, it doesn't decrease your risk of heart disease. And the killer really is that it said that it increased your risk of breast cancer. And overnight, can you imagine, you go to work one day and you're talking to people about hormones and you're like, everybody's happy. And then this comes out, this big press conference, and our phones were, lit up. And patients were saying, oh my God, can't believe you've been giving me this stuff. It's going to kill me. It's going to give me breast cancer. So it went from being a godsend to, and I use this, to being a turd in a punch bowl, like overnight. And I was like, wow. But here's the problem. We were getting that information filtered through the media and through what, NIH was, held the press conference to say. It took another 10 days for me to get my hands on the actual journal article because young people, there was no internet. You had to wait until your journal came in the mail, good old fashioned snail mail. And when I read it, I was like, wait a minute, it didn't say that. And all of the things that we talk a lot about the study that we understand that were the limitations of the Women's Health Initiative, the women were too old, they were too far beyond menopause. It doesn't, it sort of begs the question, how are you going to do a study to see if it prevents heart disease if you give it to women after most of them already have established heart disease? That was the problem. And the breast cancer data was always, always less than, what should I say? It was less than robust. It wasn't even statistically significant, but people never heard that part. And so for the next, probably, let's say that was 2000, for the next 20 years, I have spent in my office trying to explain that to women, to say, well, you know what, really, it didn't really say that, and, there is a lot of evidence on the heart disease part. It does, all the things that we talk about now. So we've gone around the world and back again, and we're back now to where we started in terms of the conversation about hormone therapy. The unfortunate thing is that that message of harm, of excess harm to women, has really resulted in a generation of women not using a very, very potent and important option for relieving symptoms. So, we've got 23 plus years now of women who have shied away from it because of the fear, not because of any real scientific data.
No, that press release really did a lot of damage overnight to a lot of people. And I was in training when that came out. And I remember overnight we had the same conversation with our attendings, and they said, just don't do it. Don't worry about it. You don't need to be giving any of that. And, that's what we were taught. And so here we are, fast forwarding, and now I have to go retrain myself as well as other people in the community. But you never stopped prescribing. You kept prescribing as if, because you knew the study, right?
And that's something that I really want people to understand is that the controversy about those findings, we didn't just discover this. It happened immediately. It happened, in the room when they announced, and even the principal investigators who were conducting these trials all across the country were like, whoa, wait a minute. You've gone too far with this, and you've actually taken these findings for women who were 63 and 12 years beyond menopause, and you could be up to 79 years old and still be in that study. Now, just ponder that for a moment. How are you going to prevent heart disease in a 79-year-old by giving her anything? Probably not going to work, right?
Yeah.
But there was always controversy about it. There have always been people who've spoken out about this. There's Dr. Robert Langer, even Wolf Udian, who at that time, the head of the, then was the North American Menopause Society. There has been a critical discussion about the findings of the WHI since 2002. The unfortunate thing is that it never got the pickup that the initial splash did. And so we talked about it, but people talked about it in conferences and, amongst themselves, amongst the scientific crowd, and it never really made it out into the general public. And even the updates that have come out, because we don't just have the data from 2002, they did a 5-year update, a 10-year update, a 20-year update now on the women who were in the Women's Health Initiative that really walked back even some of the most, egregious findings, the breast cancer thing. They're still contending is true, and it's still not. If it's not statistically significant in scientific world, then it's not a finding.
Correct.
You don't get to say, well, we almost got there. This isn't horseshoes.
Right.
You either
Right.
get it or you don't.
Or you don't. Yeah.
Close doesn't count.
Mhm.
And, the fact that they have not been able to really show an increase particularly in the breast cancer. And I really want to emphasize the breast cancer because that was really the finding. Women don't fear heart disease
Right.
the way they fear breast cancer.
Mhm.
So, it's like heart disease, oh, okay, whatever, I'll exercise and eat right. But that breast cancer, that was really the nail in the coffin in terms of how the whole conversation about hormone therapy changed. And, but here's something that I think is very difficult and difficult I see for younger people to do. If you're not there and you didn't know it, we in medicine, we have a tendency, we're good students, right? You're taught things, you believe it. And you believe what you believe because someone in authority told you that.
Mhm.
And if that's what you're taught, that's what you tell your patients. And I say, we believe what we believe until science or someone else steps in to say, hey, that's not right. Because I think a little bit of humility is in order because we have to realize that, 150 years ago, we were still bloodletting because we thought that was the answer to everything. And so, just because you believe it does not make it true.
True. Yeah.
So, going back and examining the science, and I think that there is, the story's not done. There's a lot more about hormone therapy that merits study. And you know what my fear is that studies are never going to be done. So I think for people who are critical of the WHI, I get the limitations. There were also some good things that we learned from the WHI. So it wasn't, we're not going to throw the baby out with the bathwater. We learned some things about hormone therapy. We learned what not to do.
Right.
Don't give it to a 79-year-old and expect her heart disease to get better. We understand now that timing is important, and that is data that we got from the WHI. But we didn't have as many options or form factors then as we do now. Patches weren't included, bioidentical estrogens weren't included. There was just one dose of medication, one type for older women. And we extrapolated that data over everybody and everything, which probably is not a good idea.
Right.
But I was getting back to saying that what we have got to do is sort of, now sort of re-educate and reorient doctors and patients. And I think that, this has been going on for people who think, oh, this menopause conversation is something new. I say you may be new to the conversation, but even the broader one where we bring in social media, this has been going on for years as well. This didn't, we didn't just wake up and find this out yesterday. Right. This has been an ongoing conversation about hormone therapy in a way that I think that women should be able to have the option. Should every woman take it? Should everyone avail herself of it? That's up to you. Depends upon your symptoms, depends upon your family history and your treatment goals. But to not have that tool and that medication as an option, to me, is unconscionable, that women don't even get to discuss it. And that's what we've all been working on these past few years.
Is providing that conversation.
Exactly.
In a right manner, though, not just, with old information and myths, and really debunking all of the things that people have been thinking over the years.
Right. I think that, we as, it's funny, when I was writing my book, and my book is called Grown Woman Talk, and I wrote the book for a specific reason. What I saw changing in medicine, and I've been here for a couple of inflection points over the past, 35 years. And the first one when I started was when we made the shift from, hey, doctor's in charge. You can take whatever medication I prescribe and your insurance pays for it. I didn't have to go through anybody other than myself. And then we went to HMOs. Okay, so that was a major, major sort of inflection point in how medicine was practiced. Oh, I have to say, Mother, may I, before I give this medication. That happened. And then now we're at another point. And the point that we're at in 2026 is what I call the corporatization of medical practices. And so now we went from the patients don't belong to you, they belong to insurance companies and HMO groups, and they decide, where you can go and who you can see. And now we're in a position where we are watching, not even slowly, but rapidly, doctors don't even have control. Doctors are, for the most part, employees. I think it's like 80% of doctors now practicing either work for, their practices have been bought up by private equity groups, or they're employees of, these large, either hospital groups and that sort of thing. And they are now dictating how care is given. So there's a lot of autonomy that's been lost. There's a lot of, I think one of the good things about being a physician is that you got to control your day. You got to say, hey, this person needs more time. This one needs less. I can make up here. But it was your decision to make. We weren't on quotas. We weren't evaluated by RVUs, these things which are called relative value units,
Right.
when someone is deciding how you're going to get paid depending upon your throughput, not necessarily on the quality of your care, but on the number of things. And that is another part of why I felt it was so important, because I know that patients are now getting less conversation about everything, not just about menopause. And so to be able to make the most of that time, I said, let me write a little, because I don't think patients understand that.
Right.
And they think your doctor's being short with you, or your doctor's not returning your call because they're a bad doctor. No, sometimes, but more often than not, it's just that doctors are overwhelmed. And we've got to figure out how to be better advocates for ourselves as patients, how to show up, how to know what to do, how to be efficient, such that if you've got whatever it is that you need to get addressed, you get it addressed. So that was really the impetus behind the book, in addition to talking about perimenopause and menopause, but talking about all the things that affect women in midlife, and how do you show up, and how do you sort of make the most of a system that's never going to go back and be the old way. So, doctors used to do house calls. Guess what? We don't do that anymore. Unless you pay $100,000 for a concierge doctor, and yeah, maybe they'll drop by. But we have to reckon with the changing care delivery model that we have now. So, it's a lot of stuff going on right now. And, I just want people to understand it, because are we going to change it? It'll be something else. I don't know. But I think the digital health platform is going to be a big part of it, and it will help address some of the doctor shortages that we have now as well.
Yeah. Your book has been actually quite the guide for a lot of women, just because you don't just talk to them about their bodies, but you really talk about how they can take agency of it, right? And how to go to the doctor and really help in their own healthcare decision-making process, right?
Because in addition to all of the other sort of structural and systemic changes that are going on in medicine, there's also the interpersonal relationship has changed, because I had the luxury of being in one practice in one place for 30 years. So yes, I knew my patients. I've known them since they were in high school, and now they're in menopause. All through. I know your mother. I take care of your children. I had a lot of context around my patients that in today's world doctors don't have. There is, you're going to move, your insurance is going to change, your employer, you change employers, and now you've got to pick a whole new group of doctors. all of that stuff does not really lend itself to establishing long-term continuous relationships with one physician.
Right.
And so that means that no one knows more about you than you, not your doctor, because you may be seeing a person you've never seen before, or you're not going to see a doctor, you'll see a nurse practitioner or a PA, or, there's this fragmented care now, and I watch this with my daughters, who I try to explain to them the importance, but they move around. So most things that they have a problem, they'll go to urgent care. And, and like, okay, going to urgent care is better than going to the emergency room. I get that. But the point is that person in urgent care has no idea who you are. They are going by an algorithm, and things are going to be done and diagnosed. And so that's what I'm saying. You've got to come into this realizing that you have to take control. At least you don't have to know the answers, but you have to know which questions to ask that will get you to the right answers. So that's sort of why I did this sort of guide. Mm-hmm. But the other part of it that is what was really fascinating to me was how little I actually knew about the history of how we've gotten to this point. Medicine writ large, not just OBGYN. And the people, the doctors who were revered, and again, these esteemed physicians who, started the American Medical Association and created the medical residency program and created gynecology. All of these men that we have just taken at face value because we believe what we believe, because that's what we were told, they were very complicated people, and they were men of their times. And I don't say this to negate what they did. I'm just saying this to say that the context around how our medical system was created never took into account women, and it certainly never took into account Black people, right, generally. So it is that, and those things are sort of woven into the fabric of how medicine, how care was delivered, who's important, who's not, who should we study, who not. I mean, imagine 1993, before it was mandated that women be included in clinical trials. 1993, not 1893. Right. So you know what I mean? When you understand those limitations, and it sort of it should lead us all to question some of the beliefs that we have about who gets what, who's worthy of care, and that I think was probably one of the most enlightening things for me, is that there was a lot of stuff that I just took at face value that I realized, like, ooh, who said that? Right. Not so. There was a lot of that, but that they were men, and they were men of their time, and people will look back on the things that we're doing now and they go, wow, what were y'all thinking?
Right. Like, why did it take you so long to get to
exactly
point, right? Like,
exactly.
What happened?
Exactly.
Who do you think who did you have in mind when you were writing the book? Like, was it a patient, family members, a combination?
It was really a combination, but more so, I told it as a family story because when I wrote the book, I said, I don't want this to be, a treatise. I don't want it to be like, well, I'm the doctor and do this because I said so. Right. That's how we learn. I wanted it to be, I wanted to center my experience as a physician, but also center my experience as a family member and a girl of the South. Because I've seen a lot of what happens from the other side, the other side of that desk. And when you're the youngest of 8 kids, I've got a lot of stories to tell, about family members and how they were treated. My mother died of colon cancer when I was 12 years old. And, I'm the youngest of 8, but I only have 4 siblings remaining, but the 6 of the 8 of us have had a total of 8 cancers. Wow. So that means 2 people had 2 cancers. And it just, and you kind of look at that and you go, wait a minute, well, what was going on there? And the notion is that there, well, my God, you must have really some terrible genes in your family. And it's not, and when you delve a little bit below that, you realize it's like, no, we all shared a certain environment. We all shared a certain lack of access to care. My mother, we never did preventative care.
Right.
We didn't, that wasn't a thing. You went to the doctor only when she had exhausted every possible home remedy she
Mm-hmm.
could go through, and she knew a lot. She got 8 children to adulthood, so there's that. um, but I realized that there's just a lot about how care was delivered
Mm-hmm.
and how we did not, the fear of interacting with the system that really didn't see you and didn't respect you.
Mm-hmm.
And those were the kinds of stories that I tell about my mother from 50 years ago, but they're still happening today. Because remember, you've got to take it all in context, how medicine is, and how a lot of how care is delivered today really depends on where you live, who you are, what color of your skin, whether
Mm-hmm.
people think you're worthy of care. And that is the story that I really wanted to tell, because I think unless you understand that, how are we going to change things?
Right. Yeah. And for far too long, this has been across cultural boundaries. Like it's everywhere. It's with African Americans, Latinas, Middle
Yeah,
Easterns, Southeast Asians
yeah,
across the board.
yes.
And I think what, for culturally, for my background, you didn't go, you didn't complain. You just
Hmm.
kind of
Hmm.
went through it and you didn't have time to complain, right?
Right. The doctor knew best,
And
Who
that's
am
what you
I?
say to them. Yeah. What am I going to say? It is what it is. You keep going. And if once, like you said, you've exhausted every other option, then you're going to go there. And then you take everything they tell you at face value. And
Hmm.
you don't question anything. You don't question authority. You just take it, you go, and you hope it works. Sometimes it did, sometimes it didn't. Uh,
I have to tell you a funny story, because, talking about learning the history of where you live and what that means. Um, I grew up on a funny street, and it was in the middle of, it was a neighborhood, and there were houses on my block, but there was clearly commercial interests on other sides and not very far from us. I lived next door to 2 hospitals.
mhm.
One was and when I say next door, I mean next door. One was the old Marine Hospital, pre-Civil War hospital. Um, so again, it took care of soldiers during the Civil War, yellow fever, that whole thing. And then one block from that was the city hospital, Mobile General Hospital. Okay, so I'm like, well, that's such a weird thing to have 2 hospitals, and
Mhm.
why are there houses next to hospitals? And by the time I was growing up, that old pre-war Civil War hospital, the Marine Hospital, was turned into a TB hospital.
Oh.
So they had patients in
And then
1969. I'm a kid, and there are TB patients in the
patient.
hospital next door. And you have to say to yourself, as I went through med school, I said, why were there still patients in a TB hospital?
TB.
Well, it's Alabama, so there's that. That
Uh-huh.
they hadn't heard. Oh, by the way, we have a
Yeah.
cure for that.
Right.
But but learning that I said, why did my mother? I was born at home.
Mm-hmm.
And there was a hospital that my mother, even if she were 10 centimeters dilated, she could have walked to that hospital,
Right.
should she, have chosen to. And she didn't. And, and I have to put this story together, and I say, wow, why didn't she? Because when they moved into the neighborhood, the sister who is, the next to me in age, my mother went to that hospital to have her. And it was segregated. My sister was born in 1952. Um, my mother, I'm sure, had a horrible experience at that hospital,
Mm-hmm.
you know. And before that, her kids were delivered by midwives. And so she figures, hey, I'm next door to the hospital. Let me go to the hospital. And I can only surmise that her experience in that hospital must have been horrific.
Mm-hmm.
No, totally segregated. You go in through another door.
Mm-hmm.
I mean, I'm sure it was a chamber of horrors going on there. And she had my sister, and then it was time for me. She was like, never mind. I, I got this. I'll do this at home. And I was delivered by a midwife. But the point is that even though when we talk about access, we couldn't have been closer
Right.
to a hospital. And they were like, and my mother was like, no,
No,
not
rather not.
anything but that.
Yeah.
You know, so that's why I said you have to, when I think about my family and my family stories, it's amazing to me. I think it's a testament to my mother and her, you know, her skill set that we all made it through okay with, you know, not a lot of discernible issues.
Right.
There may be some psychological ones, but not a lot of physical ones. But that was how she was treated. And you know, and so does that type of environment is not conducive to having any warm and fuzzy feelings
Right.
about feeling that doctors see you and they're there for your good and they're, you know, can be respectful. But that's the legacy
Right.
of our profession. And, you know, and we have got to understand that so we can do better.
You can do better. I want to switch gears and talk about your role as a chief medical advisor at Alloy, which is the telehealth platform for women in perimenopause and menopause. How, I know you met with the co-founders, and what made you decide to align with that instead of, you know, like, how did it, I know it was after COVID and it just happened to, you know, come across and it just felt aligned to you, but how did you go about kind of forming what your role would be and what you would want to achieve with that platform?
Well, you know what? Fortunately, I had two very, you know, when I say the founders, Anne Fullenwater and Monica Molinaro, were also coming to this discussion from a very personal place. You know, it wasn't like, oh my God, what can we do to make some money? You know, that wasn't it.
Right.
Monica's story really was, she was one of those women who had a family history of breast cancer and was a genetic carrier of, you know, BRCA1 and had her ovaries out at 40, you know, and her whole, you know, she's like, what? She was in New York City, you know, and trying to find a doctor who would address her needs and treat her with something. It was a 5-year journey that she was on before she could find someone in New York City that would finally say, hey, we can't leave a 40-year-old woman out here
Right.
with nothing. And that's sort of where she was. And finding someone, you know, in this era where there were so few doctors that really were prescribing hormones and weren't fearful of them. So that was her personal journey. And Anne Fullenwater, the other founder, her personal story was that her mother died of a heart attack in her 50s. You know, again, one of those generation of women that was never put on hormone therapy. So their motivations for starting Alloy were quite different, you know, not like, you know, oh, we'll do Alloy or we'll sell, you know, I don't know, widgets. It wasn't that. And so our missions were aligned. They were really trying to address the access problem because we all know that there are not enough doctors out there, you know, because, and through no fault of their own, it's just that there's a generation of doctors that really wasn't trained in menopausal women and hormone therapy. And, you know, if you grow up thinking that this is something dangerous and not allowable except in very small circumstances, then finding someone is difficult. So when we got together, it just, our missions aligned perfectly in the sense that they wanted to do a menopause company to improve access. And I wanted to make sure that women, if they were going to get hormone therapy, that we should be doing it in a way that was evidence-based. You know, and so that was sort of how we started. I said, well, you know what? How about this? You know what the need is. I know menopause. Let's get together and figure this out. And really, that it's not just menopause, but I think menopause is one of those health issues where it is uniquely suited for a telehealth environment or a digital health environment. All of it's going to have to go, a lot of it, not all of it, But a lot of it is going to have to go that way because, of all the things we haven't addressed the impending severe doctor shortage that we have coming up in the next 15 to 20 years. We haven't kept pace with the population. We have a lot of shifting demographics that are changing who gets access to what, particularly for OBGYNs in the post-Dobbs decision era, there are going to be a lot of places where doctors are not going to go. Why would you?
Yeah. Yeah.
So that's why we've got to, we were able, and they were good enough to give me the leeway to say, okay, we know what the need is, but help us try to figure out how to operationalize that. And that's sort of how Alloy came to be.
Yeah. And you've been with them since the inception, correct? Yeah. That's
5 whole years.
5 years. Yeah. And so a woman wants to have, a consult with an Alloy provider. Can you just kind of quickly walk us through how that works and how the model works?
Yeah. And and here's something I also want to be very clear about. If you are so fortunate to live in an area where you have a doctor who knows how to treat menopause, or you have an OBGYN who's kept up with things, do that.
Right.
That's not, there are many, many things that you're going to have to see your GYN for that are not suited for digital health. So that's clear. But our job is to really say, what about all these women? And we hear again and again and again, I've been to 6 doctors, no one will prescribe for me. Or I don't have insurance, and now I don't have access to a doctor, nor do I have access to my prescriptions. So the way it works, first off, we have all doctors. So all of our doctors are board certified. 95% of them are OBGYNs. Many of them are menopause certified. So what we do, and this is why it's so important to do the work on the front end, is that we sort of constructed, an intake process that says, okay, these are the people that can have, these are the people that need more, you need more information for, these are the people that are no, because we don't want to prescribe in a way that is unsafe,
Right.
first off. And once we do that, and it is an asynchronous model, which means that you don't have a video appointment. And there's a very there was a very good reason why we did not do it that way, because during the experience of COVID, when many of us tried to see patients, we tried to have video for
virtually this way.
It's worse than trying to see a patient in person. It is inefficient. You spend all this time. Can you hear me? Wait a minute, you're on mute. All of the inefficiencies of an in-person visit and none of the good stuff. So we said, all right, how can we do this in a way such that at your convenience, you can log on, answer all your questions, do the things that you need to do. The doctor sees it, reviews it, if they have follow-up questions, and it's all done in a way that all of us are familiar with. You text, your doctor has other questions. I need more verification for that. We go back and forth, and it's done. And then at the end of it, once you have been approved, then we ship your prescriptions directly to your door. So you don't have to go to CVS, you don't have to do any of these things. And, it makes it convenient, but it also gives you immediate access, because once you're assigned to a doctor, you get the same doctor. So you got a question. Hey, doc, I'm spotting, or should this be happening, or whatever. You are, all of your history is there, and you get to connect with that doctor for the entire time that your prescription is active. But what it does from an efficiency point of view is that it allows that doctor, through the wonders of modern technology, to be able to leverage that expertise over many patients, not just physically limited by how many patients you can see in the course of a day.
Right.
You can do it whenever. You're on call at night and you're like, okay, let me do a couple of cases. It's really at your convenience, but so it's quick, it's efficient for doctors and for patients, because you're not taking a day off from work and sitting and waiting and, hey, did you call my prescription in? All that stuff that we know, the real life things that get in the way of real practice.
Yeah, and the thing is, I think women appreciate the efficiency of it.
Mhm.
Getting to they need it. They'll go and get their pap smear, they'll get their mammograms done. But
Right,
this way, they're not sitting waiting for
right.
someone to do something and call them back or find an appointment to go in and discuss. This way, it can be done quickly, efficiently. They get on their treatment plan and they move forward with their lives.
And you know what else that we're able to do? And I actually thought about, I have a totally different appreciation for it now since I've been with Alloy, is that we have the ability to do two things. We can do a lot of the educational part of it up front. Just like this, you can click on a video. What does that mean? I can attend webinars. We have community
Right.
groups. We have community support groups for various and sundry things. So there's a lot more to it other than just click on this and get your prescription delivered to you. We try to provide all of that sort of information, all the wraparounds that if you were a doctor in your practice and you had unlimited time and unlimited resources, you could create that. But I now know it's really hard to do that in a private practice setting. Think about all the time you could save as a physician in your office if you had an entire library of videos of everything that you needed to explain over and over and over again. But to create that requires a lot of infrastructure that most doctors just don't have.
And so, if women were to kind of go through this whole journey of finding a provider, what is the one thing you would tell them at this juncture now, having been through always, with the prior to WHI, post WHI, where we are with telehealth and everything? What would you tell them?
I would tell them this, first thing is that, got to eliminate the fear factor, and I think that once you sort of eliminate that and give women the permission to be able to choose something just because it does nothing, if it improves the quality of my life. I think that too long women we've been socialized to think that just suffering is part of womanhood, from cramps to endometriosis to migraines to everything. It's just like, well, what are you going to do? You're a woman. I want women to be able to say, yes, these are the things that I need addressed. And I also tell women all the time, don't let someone else tell you how you feel. I'm having a problem and you go in and someone goes, well, you're fine, or any of that. It just means that you deserve to be respected, to have your needs addressed, and don't be afraid to advocate for yourself. And if you're not getting what you need in that particular environment, then move on. And I think that's sort of been the imbalance of power with doctors and patients. And I think that patients haven't really felt empowered to, you kind of do what the doctor says. And if the doctor says no, you're just going to go, okay, I guess I can't have that. No, I want educated, informed patients who know how to advocate. So the advice that I give in my book, the advice that I give every day is like, know what you're going in there for. Be on a mission. And once you know what your mission is, you're either going to get it answered or not. And let's just say we all know as doctors, we don't know the answer to everything.
Correct.
Of course we don't. But have a relationship with a doctor that will at least acknowledge and say, wow, I don't know what the answer is. What's my next step? So you always leave there not thinking that it's just fine. But if it's not fine, I know what the next thing is to do. Do I need a second opinion? Do I need another test? Do I need a whatever? But the answer isn't walk out of here and I'll see you next year.
Yep. Dr. Malone, I can't thank you enough for making the time to be here today. You've, enlightened us so much, and I know my audience, they're going to love listening to this, and they're going to want to know more. So where can they find you?
You know what? You can go to drsharonmalone.com. I have a website. I have a podcast called The Second Opinion. that, we discuss menopause, but all midlife things. So it's, so you could hopefully learn a little something along the way. But, and like I said, and I'm easy to find. You can follow me on Instagram. I'm S. Malone MD. I'm not the most prolific Instagrammer in the history of the free world. It's sort of like, I'm like, okay. But there's a lot of good information, and always be on the lookout, because when we're doing things like this, this is a great resource, that we have this ability to for all the wonderful podcasts that are out there. And the only thing I would caution patients about, and a lot of this has come up, is just know, if you're going to take advice in an online environment, you have to be discerning. I would tell you the same thing if you were picking a doctor. Don't just go, oh, that one. Pick the one that suits whatever your needs are, and make sure that that person is qualified to give you that information. And you know what? In my book, one of the first chapters is really how to pick a doctor. And there's a whole section in there on, well, how do I evaluate a doctor? And there's a whole thing. How do you check if a doctor is board certified, where they went to med school? All of these things that are important data points, not to mean that, that just because a person went to Harvard, they're going to be great. It just says that there's a bar about where you should take advice from. I wouldn't take, I'm not going to say anything, because I will say something that someone will be mad at me for having said that.
Oh,
I'm just
I don't
saying,
think so. I think you should say it, because we all are thinking it.
I wouldn't take medical advice from a chiropractor. That's just me. I'm an OBGYN. I'm not a dietitian or a nutritionist. I can give you the basic things about what to do, but deep diving into certain things, I don't have that level of expertise. So that's why I said, understand what information you're getting, who you're getting it from, and whether or not that person has the credentials and expertise to be able to give you that information.
Yeah. I always say, stay within your lane and just do that. And I think you're going to be okay. And, women should be discerning with their care. This is a time to do that and speak up for themselves.
That's exactly right. And you know what? And I think if you do that, and and I say to listen, trust your gut. Does this even sound right to you? Or how is this person making me feel in this interaction? And if it's not good, trust that.
Yeah, absolutely. Well, again, thank you so much. And we look forward to having you back next time.
Well, we'll see you, hopefully.
Thank you.
You're welcome. Thanks for having me.